I'm Dr. Kieron M Dunleavy. I am Director of the Lymphoma Program at MedStar Georgetown University Hospital, Lombardi Comprehensive Cancer Center. I see patients with a diagnosis of lymphoma as well as other lymphoproliferative disorders, and these patients may be newly diagnosed with lymphoma or they may have previously had treatments. My philosophy when treating patients with lymphoma is first of all to make sure that we have the diagnosis correct. This is something that can be challenging in lymphoma. There are over 100 different types of lymphoma. So from the very beginning, starting out and making sure that the diagnosis is correct is really critical to ensuring good care following that. And then I think that obviously it's very important that patients get the correct treatment for the type of lymphoma that they have, and that requires an expert in the field to oversee their care, as well as a multidisciplinary team of people who can weigh in on their care and be there to support them. The field is changing so rapidly with respect to new treatments, so it's really important that patients are able to access clinical trials in order to be able to have access to new treatments. So that is a critical part of patient care and my philosophy towards patient care. So we have a spate of new therapies that are now becoming available to patients, and these are therapies that we have not had historically. We have therapies such as CAR T cells, bispecific antibodies, cellular immunotherapies, and just a lot of other agents as well. We also have new diagnostic techniques. We can now do liquid biopsies to detect cancer cells in the blood, and this technology is very exciting and is being tested in clinical trials, and it will soon become available to many patients outside of a clinical trial setting. Yeah, patients should come to MedStar Georgetown for their lymphoma care because it is a National Cancer Institute designated comprehensive cancer center, and that means that it has met rigorous criteria that have been put forward by the National Cancer Institute in terms of quality of care, science, different programs interacting with each other. There are just about 50 NCI designated cancer centers in the US. So as an NCI designated cancer center, we really reflect the best in diagnosis, patient care, and patient outcomes, and also science that is related to all of this. Lymphoma is a type of cancer of the lymphatic system or immune system, and we have lymphatic tissue all over our body. So in the vast majority of people, we don't know what causes lymphoma. There are certain people who are at increased risk of developing lymphoma, but for the vast majority of people, we're not able to identify an underlying cause. There are some people, and this is not usual, with certain types of inherited or congenital disorders who've got a higher risk of lymphoma. Certain types of infections can put you at a higher risk of developing lymphoma, such as HIV infection. But again, the vast majority of people with lymphoma do not have a known underlying cause. So the majority of people who have a new diagnosis of lymphoma, they notice enlargement of their lymph nodes, and we have lymph nodes all over our body, and the areas where people typically notice them are in the neck, in the axillary areas, which are underneath the armpits, and the inguinal or groin area as well. But other symptoms can occur when somebody has a new diagnosis of lymphoma. There are symptoms called B symptoms, which make up fevers, night sweats, weight loss of more than 10%, and these can occur, I would say, in a minority of people who have a new diagnosis of lymphoma. People who are at higher risk of developing lymphoma include patients with certain infections, such as HIV, patients with autoimmune diseases, and the risk of lymphoma can be associated with certain autoimmune diseases, but also with the treatments that people receive for autoimmune diseases. They often are treated with a class of drugs called immunosuppressants, and these can increase the chance of developing lymphoma. Also, certain people who have had transplants, so people, for example, who've had kidney transplants, are at increased risk of developing lymphomas. Sometimes these can be related to a virus called the Epstein-Barr virus, sometimes not associated with that. And also people who have had other types of transplants are at increased risk. Then very rarely there are people who have inherited disorders that put them at increased risk of lymphomas. We don't see these patients very commonly, but there are certain unusual diseases that put somebody at increased risk of developing this disease. Yeah, so the majority of patients who come to an oncologist or come to me, they already have a diagnosis of lymphoma. And the lymphoma diagnosis is typically made by, I would say, a surgeon. So when people present with swelling in a part of their body, they're typically assessed, they undergo some kind of imaging, and then if there's a significant abnormality, they undergo a biopsy of that. That's usually under the care of a surgeon, oftentimes an ear, nose, and throat surgeon, if people present with an abnormality in the neck. And then the tissue from the surgery is analyzed by a pathologist, and it's the pathologist who makes the diagnosis of lymphoma. So that really depends on the type of lymphoma that a patient has. You can divide lymphomas into aggressive lymphomas and indolent lymphomas. Aggressive lymphomas require chemotherapy, usually with a type of drug called a monoclonal antibody, whereas a high percentage of indolent lymphomas do not require immediate therapy. And it's not uncommon when we have a patient with a new diagnosis of an indolent lymphoma that we can pursue what's called a watch and wait approach, where we don't initiate treatment. We do typically bring the patient back in a few months and see if there's been any change in their disease status, and at that point reconsider if there's a need to start treatment. But a high proportion of indolent lymphoma cases do not need urgent treatment. And then lymphomas are very complicated. As I said, there are over 100. There are B-cell lymphomas, T-cell lymphomas, all kinds of different histologies and biologies. So the treatment that a patient gets completely depends on the exact type of lymphoma that they have, and also how advanced it is in their body when they are initially diagnosed with it. Yes, I want patients to know that one of the most important parts of the whole treatment process is the initial diagnosis, and I can't emphasize how important it is to get that right. Lymphoma is a very complex area. There are over 100 types of lymphomas, and when it comes to initially diagnosing lymphomas, there are lots of nuances with respect to the pathology. So I think it is really important to have an expert hematopathologist look at the pathology initially to make the correct diagnosis, because everything depends on the diagnosis. So the type of treatment that we recommend for patients completely depends on the diagnosis. So we need an expert hematopathologist to make that diagnosis correctly in order for the correct treatment to to be given to a patient. So that is a really important step at the beginning when somebody is newly diagnosed. Yeah, so if you look at the most common type of lymphoma, that's called diffuse large B-cell lymphoma. And currently, about 70% of patients with this type of lymphoma are curable. The other 30% are not with initial therapy. And there's a lot of work going on to try to understand better why the 30% are not cured and to develop new treatments for them. Over the past few years, there have been a lot of advancements in clinical trials that have focused on patients with relapsed and refractory lymphoma, and they have seen the development of new agents such as CAR T cells and bispecific antibodies, and those approaches have led to long-term remissions in a significant proportion of people who have relapsed and refractory disease. So those types of treatments are now being brought up into upfront investigation, and hopefully we will improve that 70% or augment that 70% to a higher number. And that's a big focus of clinical trials in this disease. So if a patient has a diagnosis of lymphoma and they have lymphoma involving a lymph node in their neck and it spreads to their liver, this continues to be lymphoma. So if you took out the cells from their liver, they would be lymphoma cells. And then in contrast, if you have liver cancer and the cancer starts in the liver and spreads to, for example, a lymph node in the neck, this is liver cancer. So this does not become lymphoma. So it continues to be liver cancer irrespective of what part of the body it spreads to. And that's a really important distinction, to make, and I think it's very helpful for patients to understand that. The multidisciplinary team is really important in a patient's care. In the area of lymphoma, I would say that there are different roles for the multidisciplinary team at different times in a patient's treatment course. At the very beginning, when somebody is diagnosed with lymphoma, it's really critical that the doctor, the lymphoma doctor who's treating the patient, interacts with the pathologist who's making the diagnosis and really understands what the diagnosis is. As I've said, there are over 100 different types of lymphomas, and there are lots of nuances to the pathology. So it's really critical that the pathologist and the treating oncologist have a good relationship and interact with each other. And I always like to look at the pathology myself with the pathologist to get an understanding of what's happening on a cellular level. So that, I think, is an example of a multidisciplinary approach at the very beginning. And then when you move on to treatment, there are all different types of treatments, and they can involve different physicians. So again, it's critical that there is a multidisciplinary approach, that all of the key physicians who are involved in the patient's care are talking to each other, and that there's open communication, not just at the initial point when treatment is being decided, but as treatment is ongoing and things change. It's really important to have a core group of people who can oversee care. And then, of course, there are so many other people involved in looking after a patient: the nurses, the social workers, other physician, nurse extenders, and all of these people have a critical role in managing someone with a diagnosis of lymphoma. Multidisciplinary approach is good for patients because in order to optimally manage a disease like lymphoma, you need a number of different people to be on board and to be involved in the decision-making process. I think just having one person is never a good thing. So I think that it's always good to have a team of people who are involved in the decision making and who also take care of the patient as they move through treatment, and also in follow-up. Multidisciplinary approaches are very important. I'm participating in research at MedStar Georgetown, and also research that is collaborating with other institutions around the US. And this research is focused both on treating newly diagnosed people with lymphoma and also people whose disease has come back who have a diagnosis of lymphoma or other related disorders. With the lymphoma research we're doing, we're really trying to augment curability for patients. And this, of course, is in people with newly diagnosed lymphoma, there are many clinical trials that are attempting to do this in terms of adding new agents, new drugs to conventional platforms, testing completely new types of therapies. I mentioned CAR T cells and bispecific antibodies. And then there are also a lot of trials in patients who have lymphoma where it's come back after initial therapy. And again, these involve using new agents, new approaches, new combinations, and also trying to understand the biology of the lymphoma with respect to these novel agents, and how these agents work and how they may be combined with other agents and other approaches. So the clinical trials are available on the internet. There's a website which is run by the National Cancer Institute called clinicaltrials.gov, and the clinical trials are on that website, and eligibility criteria are typically listed, and also a contact person's information is also listed. So I would say if a patient is interested in a particular clinical trial, they can, I think, get a good sense of their eligibility just from going on that website, but there are also many people that they can contact to further investigate that and to establish if they're eligible or not. And then sometimes we don't know if people are eligible until they come for a visit, and when they come to the clinic and they're seen by the team, at that point it can be determined if they're eligible or if the trial is best for them or suited to them, or if they should be getting a different type of trial or a different type of therapy. So if patients participate in a clinical trial, they have access typically to either a new type of treatment or a treatment that's being tested against another treatment. So there's a research question there. So oftentimes they have access to a new approach for their disease. They also have also a lot of infrastructure comes with a clinical trial. So there's a whole team of people who are dedicated to running the trial. And in terms of patient care tends to be very rigorous and meticulous on clinical trials. An NCI-designated comprehensive cancer center has been designated as a cancer center by the National Cancer Institute and has met very rigorous criteria in terms of having outstanding patient care, outstanding science, outstanding scientific programs that all meet with each other. And in the US, there are approximately 50 centers that are NCI comprehensive cancer centers. So the bar for becoming an NCI comprehensive cancer center is very high, and it is I think, reflection of an outstanding facility for patient care. Yeah, patients should come to MedStar Georgetown for their lymphoma treatment because we have a lymphoma program. So we are very well equipped to diagnose and treat patients with lymphoma. That's really critical, not just when people are initially diagnosed with lymphoma, but also if they have had a line of treatment or several lines of treatment and their lymphoma comes back. And we have the expertise to make sure that they are in an optimal system for the treatment of their disease.